Good afternoon, everyone. My name is Monica Valdez-Lupi, and I'm the Chief of the Health Systems Transformation Team here at the Association of State and Territorial Health Officials. I'd like to welcome all of you to today's interactive webinar entitled CDC's 618 Initiative, Accelerating Evidence into Action. ASTHO, with support from the CDC, is working to maximize the number of state health agencies that work with state Medicaid agencies to implement activities aimed at increasing reimbursement for high-cost, high-burden chronic conditions. We're supporting the 618 initiative's in-person convening next month, as well as additional technical assistance for states that are participating in the initiative. Today's webinar features one of the states involved in the 618 initiative to talk about their work in Rhode Island in the collaborative and the work that the state would like to accomplish to implement additional coverage, utilization, and reimbursement services. This webinar is supported by our colleagues at the Health Resources and Services Administration, HRSA, who also support ASTHO's work to maximize the number of state health agencies that work with their Medicaid colleagues to implement activities aimed at increasing reimbursement for these high-cost, high-burden chronic conditions. The objectives for today's webinar include to describe the 618 project, identify ways in which the state health agencies can support the 618 initiative, describe Rhode Island's interagency collaboration between state Medicaid and public health, and finally, to demonstrate success to date in implementing the targeted interventions with state Medicaid beneficiaries. We're really pleased today to have an esteemed panel of colleagues and experts that will be speaking with you. Following my introductions, all of the speakers will present their slides. If you have a question, you're welcome to post it onto the chat box that you'll see on your screen at any time during the webinar. These questions will be used during the Q&A at the end of the presentations. You'll also have the opportunity to chat any additional questions during the Q&A session. At the end of today's webinar, you'll be directed to an evaluation survey. Please take a few minutes to inform us about the challenges and barriers you're experiencing in your state in working with your public health and Medicaid colleagues to increase reimbursement for these types of chronic conditions. Our speakers today are John Auerbach and Dr. Nicole Alexander Scott. And I'll just briefly introduce both of our speakers. John Auerbach is the Associate Director for Policy at the Centers for Disease Control and Prevention. He oversees the Office of the Associate Director for Policy, which focuses on the promotion of public health and prevention as components of healthcare and payment reform and health systems transformation. Before being appointed at the CDC, he was a distinguished professor of practice in health sciences and the director of the Institute on Urban Health Research and Practice at Northeastern University. He also serves as the Commissioner of Public Health for the Commonwealth of Massachusetts between 2007 and 2012. Under his leadership, the Health Department developed new and innovative programs to address racial and ethnic disparities, to promote wellness, including the Mass in Motion campaign, and in combating chronic disease and supporting the successful implementation of the state's healthcare reform initiative. He also served as the Executive Director and Commissioner of the Boston Public Health Commission for 9 years, where he led work around health equity, emergency preparedness, and tobacco prevention, and also oversaw emergency medical services, homeless services, and substance abuse services for the city of Boston. He also worked at the State Health Department as the Chief of Staff and also as an Associate Commissioner overseeing the HIV/AIDS Bureau during the early years of the epidemic. Following John's presentation, we'll have Dr. Nicole Alexander Scott on the webinar. Dr. Alexander Scott has been the director of the Rhode Island Department of Health since May 2015. She brings a tremendous amount of experience from her work as a specialist in infectious diseases for children and adults at hospitals in Rhode Island that have been affiliated with Brown and at the Rhode Island Department of Health. Her clinical and academic responsibilities were balanced with serving as a consultant medical director for the Office of HIV/AIDS, Viral Hepatitis, STDs, and TB in the Division of Infectious Diseases and Epidemiology at the Department of Health. She is also board certified in pediatrics, internal medicine, pediatric infectious diseases, and adult infectious diseases, and obtained her master's degree in public health from Brown. She's also an assistant professor of pediatrics and medicine at the Warren Alpert Medical School at Brown University. Dr. Nicole Alexander Scott is originally from Brooklyn, New York, where she attended Cornell and subsequently graduated from medical school from SUNY Upstate Medical University at Syracuse. I'm going to now turn it over to John to begin his overview of the 6AT project. John?
Thank you very much, Monica, and thanks also to ASTHO for its support and input into the development of the 618 initiative. CDC wants to assist the state, territorial, tribal, and local public health departments in building partnerships with healthcare purchasers, payers, and providers to improve health and to control healthcare costs through an initiative called the 6 to 18 campaign. My presentation will provide the background, current status, and goals of this initiative, and will provide you with some important tools. Next slide, please. The 618 initiative is part of one of CDC's 3 strategic directions, namely the strengthening of public health and healthcare collaboration in the context of the rapidly transforming healthcare system. It's important for those of us in public health to strengthen this collaboration because of the unprecedented opportunities to expand prevention and population health as components of healthcare and to move in the direction of an integrated health system with more of an upstream focus rather than a healthcare system that has its resources concentrated in the acute care sectors. Throughout the nation, there are meaningful discussions that are taking place now that involve governors and other elected officials, insurers, and healthcare providers to redesign health systems. We've been saying for some time now that public health needs to get to the table where these discussions are occurring in order for us to be taken seriously and in order for us to have a voice. Next slide. But the question we're focusing on today is, once you get to the table, what do you do? The purpose of 618 is to give you some of the tools that will help answer that question. Next slide, please. But before we dive into 618, let's just step back for a moment and remind ourselves why being at the table matters. And let's look at a person who's been affected by some of the changes recently. Miss Fran Edwards has recently become insured, and so she's benefited from the health insurance that's available with healthcare reform. And she's also benefited from the availability of clinical interventions. So she now has medication to help to treat her asthma and her high blood pressure, medications that she wasn't taking before when money was an issue. But she does still have a number of health issues, and they include the fact that she smokes, she's overweight and doesn't get much exercise, she has asthma and high blood pressure. Next slide, please. So while insurance and quality care help Miss Edwards and help her a good deal, they aren't enough to guarantee that she'll have good health today or in the future. And this slide indicates some of the reasons for that. She has a relatively low income. She's in a neighborhood that is not as safe as it could be. Exercise and access to healthy food are difficult for her. And she's living in housing with mold and ventilation problems that trigger and exacerbate her asthma. Next slide, please. And this is a reminder that those of us working in public health have to consider a wide variety of approaches in order to promote the public's health. And this can be confusing, particularly as we enter the discussions with other sectors, healthcare included, whose understanding of the terms preventive care and population health may be different than our own. To help to clarify this, we at CDC have conceptualized the framework that is on this slide. It presents a notion of 3 buckets or 3 components that link clinical care and public health. First bucket includes traditional clinical preventive services, many of which are now covered benefits without cost sharing under the ACA, but utilization may still be lower than we wish it was. Bucket 2 involves innovative opportunities to extend care outside of the clinical setting into the community or into the home, for example, through the use of community health workers to assess asthma triggers in the home. And Bucket 3 includes community-wide interventions that reach the entire population, for example, through the passage of smoke-free policies that allow all communities to breathe smoke-free air. We believe that it's important for public health to attend to each of these 3 buckets, but one or the other of them may be more appropriate depending on the setting that you're in. Before moving off the slide, I will note that if you want more information about the 3 buckets of prevention framework, there is an article that is being published in the next issue of the Journal of Public Health Management and Practice. If you get onto their website at www.jphmp.com and click on the Publish Health Ahead of Print, it is available, though, today. Next slide, please. The 618 initiative focuses on buckets 1 and 2, those buckets that have to do with clinical care to a patient, both traditional and innovative, and those services that might be paid for by the healthcare delivery system and the insurers. I'll have more to say about Bucket 3 later in the presentation. Next slide. If we want credibility with the insurers and the providers, we need to understand their priorities and their time frames, and often the relevant discussions that are taking place with insurers and providers involve efforts to make the business case or the return on investment for services that we'd like to see covered. In order to do that, we need to show and prove that there will be a positive health and cost impact in just a few years if the insurers pay for the interventions we're proposing. CDC developed the 618 initiative to promote the adoption of evidence-based interventions that we can demonstrate will improve health and reduce costs in a relatively short period of time. The name 618 comes from the initial focus on 6 high-burden health conditions and 18 evidence-based interventions that can improve health and save money. Next slide. This shows you what the 6 high-burden, high-cost health conditions are. With each of these, we wanted to make sure that there was a strong evidence base with interventions where we could summarize the information and present it to the insurers in order to make a strong case. So these six health conditions all are high cost and are of interest to insurers. Next slide, please. And then within these 6, there are 18 evidence-based interventions where we have gathered the evidence, we put it into a format that makes it easy to present to insurers in language that they understand. And we've got packets that are available to you for each one of these. This page offers just a few of the examples of those 18 interventions, and it divides them for the purposes of illustrating the examples into Bucket 1 and Bucket 2. Bucket 1, as you can see, includes the elimination of cost sharing for key services such as hypertension medications, as well as coverage of comprehensive tobacco cessation services, and no barriers to long-acting reversible contraceptions. Under Bucket 2, some of the examples from the 18 include home visits for asthma care by community health workers. It includes self-monitoring of blood pressure by patients in their home, and it includes access to the diabetes prevention program, a multi-session approach often provided in YMCAs. Next slide, please. To give you some sense of the work that we're doing on the 618 initiative, there are 4 bullets on this page. The first involves the fact that we are training CDC's employees to have a better understanding about how the work we do relates to the insurance industry and healthcare delivery system. So we've offered what you might call an insurance industry one-on-one course to many people at CDC, and we can offer you materials if you're interested in offering that kind of training to those of people in your own department. Other examples of the kind of work we've done is where we've had the health economists at CDC study the methodologies that are used by insurance company actuaries. So if we're making the case, we're doing it in the language and using the methodologies that the insurers use. Second bullet highlights that we have strong connections with, in fact, unprecedented connections with CMS. CMS is now a full partner in approaching population health. They're doing some innovative work, such as the State Innovation Model grants, and their population health group has a number of other outstanding examples. We've also worked increasingly with Medicaid programs. There have been some small summits that CMS and CDC have recently convened, and we've done a conference call where we've identified now several states where the Medicaid director and the state public health director are interested in focusing on 618 in some specific concrete ways, and we'll be working with them on a one-on-one basis, adapting the support we provide to the conditions in each state. So the third bullet highlights that we're working with commercial payers, and here we've invited the largest insurers in the country to spend time at CDC, where we've rolled up our sleeves and made proposals out of 618 for the kind of initiatives that they can cover, and we're in discussion now with a number of these large insurers about developing pilots. And then finally, that last bullet is the importance of making sure that we're providing information, toolkits, skill building to our partners in public health and at the community level, so that you feel comfortable about understanding how this approach may be useful for the work in your state and community. Next. If you're interested in obtaining some of the materials that I was just referencing, you can get them through our newly developed website, which is www.cdc.gov/ and then spell out the words 618. So that's cdc.gov/618. On that website, you can get a brochure. You can get frequently asked questions that will be answered about the initiative. You get individual evidence packages for the different interventions. And we also, independently of the website, can through ASTHO, can get you copies of slideshows and PowerPoints. Next slide, please. Now, you might be asking yourself, are there other clinical steps that will go beyond the initial 618 interventions, the 6 conditions and the interventions I've been referencing? And the answer is yes. We'll continue to use the word 618, but we're working with other divisions at CDC so that we can develop the evidence base for those interventions as well, and expand the number of conditions that are being addressed in this manner and the number of interventions. And over time, in the coming year, you may be hearing more about that. Independently of this work, you may want to use the 618 approach in your own state or community. If you've already identified, for example, a health condition that's a priority for you that's not included in 618, we encourage you to use the same approach that we've adopted with 618, which means to gather more information about the needs, processes, and priorities of the payers and providers to whom you make a proposal that there be increased coverage, to make sure to pay attention to the evidence base and be prepared to make that business case, to find the table and get to it, and then to make proposals, concrete and specific proposals about the way to expand population health and prevention services with insurance coverage. Next slide. Now, I did want to say just another word or two about Bucket 3. As a reminder, Bucket 3 includes the more upstream community-wide population health approaches, those that are not patient-focused. And those are ones that public health has long taken the lead on, and many of you do outstanding work in this area already. but we've certainly heard from a number of individuals across the country that it would be helpful if we also summarize the evidence base for a number of these bucket 3 or population-wide initiatives and made the business case for those. Next slide. So to help, we've developed already some tools that you may find useful. We have 3 websites that provide background information that may be useful in making the case for bucket 3. One focused on social determinants of health, one on health and all policies, and one on the Community Health Improvement Navigator. If you get onto the CDC website and just Google and just search for these, you can find these websites. And then coming soon, we're developing a kind of 618-like approach to summarizing the evidence for those population health-wide interventions that we can demonstrate have a relatively short-term impact on cost and health outcomes. Next slide. Now going back to 618, the first 2 buckets, this slide just gives some examples of what each sector can do in order to promote 618. I'll highlight here what the public health sector can do, and that is, again, getting to the table and being prepared with a toolkit of approaches so that you're prepared to make suggestions about the population and prevention services that should be covered by insurers as the health system is under redesign. That may involve contacting and working with your Medicaid program. We really encourage all public health agencies to strengthen their relationship with their Medicaid programs and to think about concrete and specific campaigns that they can engage in together. We're happy to offer some proposals and best examples of where that's already occurring. We also recommend taking a look at what's being funded now with public health funding within your agencies and consider whether or not it's possible to align those initiatives with the 618 approach or with other approaches that are taking place as the insurers and the providers are thinking about expanding population health and prevention. And finally, we think it's important to consider how to play a leadership role in gathering data that can demonstrate the impact of healthcare and payment reform, and in particular, those efforts that are focused on population health and prevention. Next page. So on this slide, I just want to go back again to Mrs. Edwards and to summarize in a very concrete way how a 3-bucket approach with a 618 lens to it can help an individual person. The payers and the providers can focus their attention on a patient like Mrs. Edwards on making sure that she has no copays for her blood pressure and her asthma medication, because we know copays can result in some patients not getting the medications when they need it. They also can pay for home visits to reduce her asthma and reduce some of the triggers in her home. Hospitals, through their community benefits, can pay for investments in healthy housing options in the community and support for overall community policies. And then public health can be working in the buckets 1 and 2 at those tables we were describing within the states and communities, as well as doing the traditional bucket 3 activity that focuses on various approaches, including regulatory, legal, and policy approaches that improve the health of all residents of a community. So finally, with the last slide, please feel free to go to the CDC website. We want to do as much as we can to be supportive of the efforts that you're involved in to strengthen the linkage between public health and clinical care and to improve health within the country and reduce health care expenditures. And now I'll turn things over to Dr. Alexander Scott.
Hello, John and colleagues. Thank you for that excellent presentation. Can everyone hear me okay? Or can you, John? All right, good.
We can hear you.
Okay, great. And thank you, Monica, as well, for the introduction earlier. So I'm the director of the Department of Health in Rhode Island, and also want to acknowledge my wonderful colleague, Anya Wallach, who is the director of our Medicaid program in Rhode Island. And so I'm thrilled to have the opportunity to continue to partner with her, as we're both relatively new to our roles. And so this 618 framework provides an excellent structure for us to build upon. Also, I'd like to take a moment to introduce two of my colleagues who are joining me today from the Rhode Island Department of Health as we look at applying 618 to Rhode Island and what it looks like. First is Julian Rodriguez-Drix, who is the manager of our asthma control program, who you will hear from, and as well Erin Bowles-Welsh, who is the manager of our tobacco control program. They are both involved with doing fantastic work in Rhode Island regarding the prevention efforts that are needed, and it connects well with the fact that we've chosen asthma and tobacco to be our initial 618 charges to focus on. So you'll be able to hear from them firsthand, which will be good. So I'll start with giving a general overview of our approach on 618 and touch briefly on how it fits into the current climate in Rhode Island. There is a strong interest from our state in all 6 areas of 618. It falls very well within the strategies and priorities that we have set forth as a department. 3 leading priorities of addressing social and environmental determinants of health first. Second, eliminating disparities of health and promoting health equity. And third, where this applies very well, is ensuring access to health services for all Rhode Islanders, including our vulnerable populations. Those 3 leading priorities serve as the framework for the population health goals we have outlined, and the 6 areas of 618 fit within each of the components of those goals. And that's why we're able to go with asthma and tobacco as our initial focus. So these 618 efforts will build off of the long-standing work that's been in these areas and help us strategically address barriers that we have seen in the populations most affected by asthma and tobacco by partnering with our Medicaid colleagues. This 618 opportunity allows us to move forward to advance the existing initiatives that we have in place to make sure that there is proper alignment. So from a background standpoint, Rhode Island has been coordinating already on a variety of related efforts that we hope to really maximize by taking on 618. We have a focus on preventive health services and screenings and how we can make sure that they apply best at the population health level. We have a number of evidence-based programs, and we've done a tremendous amount of work with community health workers in the state, and I'll get into how that can fit in a little bit more in a few minutes. From a Medicaid standpoint in Rhode Island, we predominantly have a system that's set up through managed care, that's referred to as Right Care. There are 2 managed care organizations, United Healthcare Rhode Island and Neighborhood Health Plan of Rhode Island. And recently, our governor, Gina Raimondo, did a fabulous job, really, charging the state with reinventing Medicaid. And so with her leadership very early on in her tenure, a task force was convened to shift Rhode Island from a volume-based system to one that pays for better outcomes and value. And the goal for us as a department and as a state has been to link that broad, necessary goal of shifting from volume-based to value-based to the specific population health outcomes and improvements that we're looking for, such as in asthma and tobacco. And so the challenge has been to connect all of the moving parts that are going on within healthcare reform in Rhode Island. So one of those moving parts is our state innovation model grant, which we have, and we are fully engaged in the first step of that grant, which is to develop a population health, behavioral health, statewide plan that will include strategies to help us shift from a volume-based system to one that pays for better outcomes and value. We also have a strong patient-centered medical home initiative in the state. The one for adults, the Care Transformation Collaborative, has been in place for many years, and we're starting to see the population health outcomes of that. And the second is also now following suit, the Patient-Centered Medical Home PIDS, which is the pediatric initiative that's getting that started. And in combining those two, what we are looking to do is establish or build on the structure of the Patient-Centered Medical Home Initiative to provide the strategies that SIM will need to bring us as a state from volume-based to value, with specific focus on some of these population health disease outcome improvements, such as asthma and tobacco. Our third statewide initiative that we also want to make sure is front and center and in place is the Rhode Island Department of Health Health Equity Zones Initiative. And that's where funding that we had typically or previously received in silos is now being used to forge coordination and collaboration to better address patient health outcomes at the population level in the communities that most need it. So we're partnering with community organizations on issues that will help us address social and environmental determinants of health, community clinical linkages, and community health teams. And so for the final part of our background to set the stage before I pass it on to Julian, I will build a little bit more on the community health teams model and how we're fitting community health workers as a key profession within that. As we look at our statewide reform, and we know we need to use that to shift from volume-based to value-based, we know that a big way to address these diseases, such as asthma and tobacco, is to get into the community and overcome the barriers that folks in those areas are seeing on a daily basis. So we're using the patient-centered medical home structure to develop community health teams, and are talking about requiring or formalizing a way to make sure that community health workers, the type of community health worker, is included in those teams so that we know as we're addressing their health outcomes, we're getting out into their homes and into their communities where social and environmental factors truly impact where health is determined. And we cannot do that unless we are partnering with our insurers and with Medicaid, who can understand the need for making sure these activities are covered. So the community health workers model includes what you'll hear about with the asthma home visitors, as well as the tobacco cessation work that's being done. And we're considering the broad term of a community health worker as being a frontline public health worker with a close understanding of the community served, who can improve the quality and cultural competency of the service delivered while building individual and community capacity. So outreach, community education, counseling, social support, and advocacy can be implemented by engaging these community-based professionals who can get into the home and really help make a difference in the treatment and health outcomes that we need for a population. So that's to set the stage, and we'll go through 2 examples of how we're working on that with asthma first and then tobacco.
Thank you, Dr. Alexandra Scott. My name is Julian Rodriguez-Drix. I'm the asthma program manager. I'll be going through these slides pretty quickly just to give a brief overview of what we have been doing in Rhode Island around asthma and in partnership with our colleagues at CDC and the National Asthma Control Program. What I will be summarizing here is the result of a long-term foundation that we have been building for years and have been building the evidence to put a business case forward and really see 618 as an incredible opportunity to move that forward into action and implementation in partnership with Medicaid. So we started with the CDC Chronic Disease Cost Calculator. The statistics that you see here, even in a very small state such as Rhode Island with a small population, we still have significant costs just in Medicaid related to asthma in terms of total costs, and also specifically zeroing in on how can we reduce the costs of unnecessary asthma hospitalizations and emergency department visits. Next slide. Within the 18 evidence-based initiatives that are part of 618 to begin with, we're focusing on the 4th of the 4 asthma interventions listed, and this one has to do with home visits. So expanding the access to these home visits with both a licensed health professional and qualified lay health worker is what we are doing here in Rhode Island. And the curriculum, as you'll see in a minute, includes both the self-management education as well as reducing the home asthma triggers. The program that we have that fits in very well with 618 is called HARP, the Home Asthma Response Program. The goal is to reduce these preventable ED visits and hospitalizations, specifically among low-income pediatric asthma patients, through our home visiting model. Our model involves 3 home visits with a certified asthma educator and a community health worker. It also includes environmental supplies, such as mattress covers, vacuums, food storage containers, and some instruction on how to use those supplies that the community health worker is instrumental with. This model was also included as part of the expansion on a region-wide basis. We had an initiative that was funded through a CMS Innovation Award called NEAC, the New England Asthma Innovation Collaborative. So we're partnering with this across New England as well, while focusing our implementation within Rhode Island. The HARP program starts with the identification of children who have more than one or more ED visit. We are restricting that slightly, and I'll get into that in a moment, based on the analysis we have for return on investment, of really finding where it is most cost effective. There's the referral for home education. The education is provided by the certified asthma educator, and then a healthy home assessment and follow-up with the community health worker. The community health worker comes to the 2 follow-up visits and brings the supplies, the remediation of allergens and triggers, does the referrals for appropriate services and supports, and links it back to connect with primary care provider in order to coordinate around the asthma action plan and any other items necessary to really build that bridge with primary care. We have been doing various levels of evaluation, and most recently doing a return on investment analysis based on claims data. So we are doing a 1-year pre compared to 1-year post analysis of HARP. Although there have been over 350 families that have gone through the HARP intervention so far, the initial analysis is with the early participants who have had, 83 children were available within that initial analysis. Of those, only 49 were able to be analyzed with claims data based on having a full set of claims data continual from 1 year pre to 1 year post intervention. Within that, ED visits reduced from under 82% to 16%. Hospitalizations reduced from 12% to 0%. Next slide. there was a reduction in both overall asthma costs and a much greater reduction in the specific ED and hospital costs. So 53% overall reduction, which is around just over $1,000 per patient. When we look at just the ED and hospital costs, it was a 92% reduction in costs of $1,175 per patient. When we zeroed this in and looked at the higher utilizers, which we defined as participants who had initially more than one ED visit and or an asthma hospitalization, we saw an 80% reduction in the overall asthma costs, which was saving just over $2,500 per patient, and a 92.6% reduction in the ED and hospital asthma costs, with a reduction of $2,267. In the first set, the intervention was cost-effective. In the second set of the high utilizers, it does show a strong return on investment, in which the initial investment was, the savings are more than double the initial investment. So where we are now, we've been bringing this data. We're in communication with Medicaid statewide, and previously we've been talking with the individual managed care organizations. And what 618 will hopefully be making possible for us is to get some additional technical assistance on analytics, the economic analysis, and helping us take all these pieces we have and combine them together to make a robust business case that can look at the Rhode Island Medicaid asthma data and build some really robust projections for realistic cost savings, which can then be used in decision-making around how to incorporate this logistically into the managed care environment, looking at capitation rates in the contracts, and implementing it on a statewide level. So basically taking the evidence we've built over years of doing grant-funded work and moving it forward to a statewide reimbursable model. And with that, I'll turn it over to Erin Bowles-Welch to talk about tobacco.
Great. Thanks. Rhode Island, we're very fortunate that we're able to work on two initiatives within 618. On the issue of tobacco control, I should start by saying that in Rhode Island we're in a really great position. We have a fantastic tobacco cessation foundation to work from. We do have access to all 7 medications that are FDA approved for smoking cessation, and that is inclusive of over-the-counter as well as prescription. Also, our Medicaid recipients have access to individual, group, and telephone counseling. So we have this great foundation of policy. What we'll be focusing on with this initiative is removing barriers to accessing these interventions. So we have what we hear from the ground is that Medicaid recipients often find barriers in accessing this, specifically around being requested to seek prior authorization for tobacco cessation treatments, and this is not a prerequisite according to the policy. Often what we hear is that a recipient is interested in tobacco cessation is told that they need to enroll in counseling before they receive medications such as the patch. That is not a prerequisite. Or that they're told by the MCO, by the managed care organization, that they can't go straight to using a nicotine replacement therapy gum, that, for instance, maybe they need to start with a Chantix or a patch first. That is not the case. Or that there are limits on the duration of the treatment or limits on the number of quit attempts they can make a year. So what we're looking to improve by working with Medicaid on 618 is really the communication of these policies to the MCOs, make sure that the healthcare providers understand what these policies are, what they can give their patients access to, and make sure that recipients know exactly what they're entitled to as well. So we'll be looking to, again, strengthen this strong foundation that we have, working with Medicaid to help them communicate and reinforce support for comprehensive tobacco cessation coverage that will remove barriers to accessing tobacco cessation treatment, and in helping to support our Governor Raimondo's task force that will shift Medicaid to an outcomes and value-based system. We hope that participation in this initiative will increase utilization of tobacco cessation benefits. In Rhode Island, we're so appreciative of the opportunity to participate in 618 and really applaud the CDC for helping to put this together, and we look forward to working with our state Medicaid office to move this forward. We're done.
Great. Well, thank you very much for both of those presentations from our colleagues at CDC and the State Health Department in Rhode Island. Again, this is Monica Valdez-Lupi from ASTHO, and I want to thank everyone for putting your questions in the chat box. What I'm going to do now is read through the questions that we've received. If we don't get through all of these questions, what Courtney and I will do is include it along with a copy of the webinar and the slide decks that we showed you today. So we'll do our best to go through each of the questions that we've received. So the first question comes from Shirley Sherry, who was curious as to why community health workers were called out and not others such as health education specialists. And perhaps, John, that question is best directed to you.
Sure. Well, as I mentioned, when we were developing 618, what we looked at was the already existing evidence base. And so we looked for research studies with strong methodology that had demonstrated it was possible to improve health and reduce or have an positive impact on cost in a relatively short period of time. That involved identifying a number of studies that specifically spoke to community health workers as those who had been studied. That said, there may well be other research that has been done that we can refer to as well. And so if the person asking the call would want to refer us to particular studies we may have overlooked that addressed the positive contributions of others, we're happy to take a look at those and to consider whether or not they should be added to the evidence base.
And I can also add very quickly, Monica, this is Nicole Alexander Scott, Rhode Island. In case that question was towards us as well, we're looking at a community health worker profession as a very broad term that includes a variety of specializations such as the home visiting asthma role and some of the tobacco cessation and even the education component that you mentioned. So what we're doing as a state is establishing a bare minimum certification for community health workers so that there is a standardization that we're all familiar with, and then above and beyond that there can be people who are specialized with specific skill sets regarding education on a particular topic or home visiting specific to a particular area. I just wanted to throw that in.
Thanks. Thanks for explaining how it looks like on the ground in terms of that umbrella category in terms of the CHW workforce. The next question is from Beth, and I apologize if I'm mispronouncing the last names here, Beth Palo. She thanks both of you for your presentations, and I think this one goes to you, John. Can you please explain the differences and similarities between the 618 initiative and CDC's Winnable Battles?
Sure. There is overlap in terms of looking at the high burden conditions. You'll see that many of the winnable battles are reflected in the 618 initiative. 618, they were developed with different goals in mind, but both goals had to do with looking at high burden, high cost conditions, and both involved looking at there is a strong evidence base for prevention. With 618, though, we had a very specific lens, which is we were looking for studies that had a strong methodology in terms of both cost and health outcome with a relatively short time frame so that we could make a focused argument with insurers about insurance coverage. The Winnable Battles approach includes some of those short-term interventions as part of the action steps, but it also includes a variety of other approaches that can be taken, including some of those total population initiatives I was mentioning under Bucket 3.
Great. Thanks, John. Next question is from Dwayne Stansbury, who asks, have you considered adding mental and behavioral health to your 6 high-burden health conditions? This is an area that we have difficulty finding adequate coverage and reimbursements.
We share your interest in paying a good deal of attention to behavioral health conditions, and we have an interest in looking at the evidence base for those as well. So we will be paying attention to that and seeing if there is a strong enough evidence base to make the case for particular types of intervention that aren't routinely covered by insurers. And we're happy to hear of suggested areas where you think there are interventions we should be examining to see whether the evidence base is strong enough.
Thanks. And I think this is another one for you, John. This is from our colleague, Jeff Engel at CSTE. Does CDC have initiatives in workforce development for 618, particularly interprofessional education, as is being developed in CCEL's DSEPD or the Population Health Branch?
We are in the process of investigating those and considering how to make sure that as 618 continues to develop, there is attention being paid to workforce issues, and we'd love to work with the CSTE on that because of your knowledge and expertise. But we are having some internal discussions as well. So please give us your thoughts about where we should be paying attention on that.
Okay. And I think this question goes to the Rhode Island team. It's from Kulthum Abdel Mogaif. Would you elaborate about how patient-centered home visits can help in tobacco control activities?
Hi, this is Erin from Tobacco Control in Rhode Island. Our program is not designed for specifically home visitors to be providing tobacco cessation counseling. We do have a program where tobacco cessation counselors are embedded in the community, specifically through community health centers that provide group face-to-face counseling, but we don't have that happening in the home.
So, and I'll add, the patient-centered medical home provides a structured model that looks through the lens of how can we connect this person here in the clinic to the needs they have in their community, because we know that's what's actually determining their health, those social and environmental factors. And we want to tailor that to the system or the mechanism that will work best. So Erin's example shows how that patient-centered medical home model within the community health center allows us to connect the tobacco cessation work with programs and opportunities available in the community that will best suit the needs of the patient and improve our population health outcomes.
We'll take 2 more questions here. The next one is from Sarah Wright, and this is for you, John. Are there current grant opportunities for other states to implement the 618 initiative?
There aren't current grant opportunities. We haven't had a specific line item in our budget that has focused on that. Instead, what we are offering is technical assistance, access to educational materials, opportunities to participate in some learning collaboratives. And we are, however, working with our CDC colleagues in the different centers and divisions. And as I'd mentioned earlier, we're paying a lot of attention to internal training at CDC. And so it may be possible to include within the work plans for certain categorical funds that you get now, activities that are 618 focused. But in order to determine that, you'd have to have the discussions of that with the project officers for those grants.
And the final question that we'll be able to take on the call is from Artis Davis, and this one is for you, Dr. Alexander Scott, and your team. Artis asked this: Rhode Island's high-level decision at the governor's level to shift Medicaid from volume-based to value-based reimbursement seems to be a really critical background piece to your ability to achieving success in Rhode Island in relation to 618 to date. Are there lessons learned from the Rhode Island experience on how this high level of impact might be generalizable to other states?
That's a great question. So, the biggest lessons learned that I think we all continue to be reminded of is to make sure that all elements of those high levels are communicating as actively and as consistently as possible, because there is such great work going on, given that the governor has done a good job really setting the bar high and charging us. We have to catch ourselves from going too far down a particular path in that great work, be it the Reinventing Medicaid or the Working Group for Healthcare Innovation that the governor started, or our Health Equity Zone work, to make sure at some point, okay, how are we each connecting? Where is there leverage? And where can we make sure that consistency is kept in our messaging? So the best example is we've put a lot of effort into making sure that when we talk about the Population Health Behavioral Health Plan that our SIM effort is charged with doing, that can be the same plan that the Working Group for Healthcare Innovation says that they want to write, and then that also becomes the same plan that our legislatures required us to do from a healthcare capacity standpoint. And we're there, but it takes active engagement to say, oh, it's the same plan, let's keep it all the same. And then that helps us better develop structures such as the patient-centered medical home and the community health teams, and what we're talking about, getting a variety of types of community health workers to be a part of that, getting those structures to advance and move forward with consistent communication, where we and the Medicaid program with Anya's great leadership can partner and actually make stuff happen. So I would say that's the active part of the lessons learned, is to make sure we continually connect the dots that are moving. It's great that things are moving. We just got to make sure that they're moving simultaneously and all communicating.
Thank you so much. And I want to wrap up by thanking all of the participants on the webinar this afternoon. I wanted to also remind you from earlier that at the end of the slide deck and this webinar, you'll be directed to an evaluation of the webinar. It's really helpful for us to gather your feedback, and it helps inform the types of webinars and speakers that we line up for our members. I'd also like to thank HRSA for sponsoring this webinar, and a special thank you to our speakers, John Arabak, Nicole Alexander Scott, Julian Rodriguez Drix, and Aaron Bowles Welsh from Rhode Island. The presentations and the responses to the questions that we weren't able to get through from today's webinar will be available on our website in the next few weeks, and the web address is on your screen now. Please be on the lookout for our newsletters and the links for more information regarding upcoming webinars. If you'd like to subscribe to ASTHO's Primary Care and Prevention Network newsletter, if you have any follow-up questions, please feel free to contact Courtney Bartlett, and her email should be up there on your screen. We hope that all of you will be able to use what you've learned in this webinar as a resource, and we'll share all the materials with everyone once they're available. Thank you very much again, and hope you all enjoy the rest of your day. Thank you.
This concludes today's call. You may now disconnect.
I don't know, John and Nicole, if you're still on.
Oh, thanks, Monica. Still on.
Great. We got almost 300 participants on the webinar. And we didn't, I think there were 9 questions that we didn't answer, and you got through 11 of them, I think. It seems like we got through most of, we got through half of them, I think. So.
You're such a good facilitator, Monica.
Oh, thanks. Well, Courtney makes it easy. She does a lot of the prep work. So, John, how would you like us, and I don't know if Nicole's on the line, but for the questions that we received, can we send them to you and Laura to help us get some of the responses?
Yeah, that's a great idea, because we can,